نبتدي يا وائل.
Yes, everything is okay now.
طب
You
انا
can
صوت
start.
واضح؟
في ويلكم مسج للدكتور ناصر، ما تنساش دكتور حسام.
صوت
Yes,
واضح
yes.
اقدر اتكلم؟
Yes, Dr. Nasser, you can start now, Dr. Nasser.
Okay. Let us start the third webinar of the Egyptian Society of Neurological Surgeons. As president of the Egyptian Society of Neurological Surgeons and on behalf of all Egyptian neurosurgeons, I would like to welcome our great speaker, Professor Mehmet Zelili. I would like to welcome our great colleague, Professor Mohammed Mohieddin Basyouni. I would like to welcome our great colleague, Professor Hussam Salahuddin, Professor of Spine Surgery and Orthopedics. Thank you very much. I give the speech now to the moderator of this session, Professor Hussam Salahuddin.
Well, Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Nasser El-Ghandour, Professor Omar Hamad, Professor Mohammed Mohieddin, and indeed all the members of the Egyptian Society of Neurological Surgeons. I'm a humble orthopedic surgeon among you great guys. So it's a great honor and a pleasure to moderate and speak in front of you and with you. And in itself, this is in its own right a message, a very clear message. It's a message to everyone, orthopedic and neurosurgeons, that finally neurosurgeons and orthopedic surgeons with interest in spine surgery are putting hands together to give better service and have the ultimate spine surgeon. There are definitely skills of neurosurgery and some orthopedic skills as well that complement each other to get the ideal neurosurgeon, the ideal spine surgeon. So thank you again, Professor Nasser El-Ghandour, for the opportunity. I would like to welcome, of course, our guest speaker, Professor Mehmet Zelili, Professor of Neurosurgery of Ege University, Turkey. Thank you very much for joining us. And also welcome Professor Mohammed Mohieddin, my dear friend and brother, Professor of Neurosurgery, Cairo University, and also head of the Middle East Spine Society. As per the program given, the first speaker, Professor Mehmet Zelili, will give his first talk. He will talk about occipitocervical fusion. Professor Zelili. Professor Zelili, you're muted. We can't hear you, Professor Zelili. You're muted. Could you please unmute yourself? Dr. Wael.
I will unmute him.
Yeah.
Okay.
Okay. The host must unmute me. Because of that, I was not able to talk. I'm very appreciated for this nice invitation. I thank all the organizers for this nice webinar, especially Dr. Nasser El-Ghandour, Professor Omar Hamad, and Dr. Hossam Salah, and Mohammed Mohi. I'm sharing my screen. Yes. Is it okay? First of all, I will start by introducing you a society which is not very well known, Cranial-Vertebral Junction and Spine Society. This is the website. I'm the vice chairman, and Professor Atul Goel is the chairman of the society. There is also one journal with the name of Journal of Cranial-Vertebral Junction and Spine. This is my presentation order. Is there a problem with occipitocervical fixation? First of all, the answer is yes, because there are unnecessary occipitocervical fixation. Many cases with C1, C2 instability only are going to occiput C1, C2, or even lower cervical spine fixations. However, occipitocervical fixation significantly restricts head movements and has a very high non-union rate. If you look at the anatomy of the region, occipitoaxial joint is a very strong joint, and the ligaments are very powerful there. In most of the cases of instability at the region is because of atlantoaxial joint instability, not the other areas. Are complications? Yes. For instance, if you wanna fixate occiput with the cervical spine, then you must place a screw in the occiput. CSF fistula may develop, cerebellar hematoma may develop, and very heart-related complications can be seen. A study from Vaccaro and co-workers has shown us that the non-union rate in this area is about 50%. It's quite common. You will expect more non-union if you use allografts, if the low bone quality, if there are severe deformities and hyperlordosis. And it's not very uncommon to get rod fractures, screw loosening, and increase of deformities. This is one of the cases I have seen with bilateral rod fractures. This case had a orthodontoidome. We had fixated with C1, C2. 2 months later, the lower screws were broken. 3 months films you can see here. And we went down one more level, but the upper screws then have been broken. It's not very uncommon. And rigid forms of internal fixation has a significantly lower complication rates than the non-rigid fixations one. And if you look at the technical evolution, historically we were doing long fixations, applications to all crâniocervical pathologies without reductions. And currently we are making shorter fixation with separate indications, and reduction could mostly be achieved. These are historical, probably our young colleagues do not know those. Luque-Hartschild rectangle or Hartschild-Ransford loops. It was being applied in the beginning of my career. You can even use wires with loops and plates or bone cement. These pictures, these photos are taken from a atlas, spine atlas. I have also used a similar one. You can see both sides a plate which was bent accordingly and fixated using multi-filament titanium wires. In sometimes I have also used hook systems like you can see here. 2 plates, or then we switched to Y plate. Why did we use Y plate? Because in the middle of the occiput, the bone is thicker and it's better to fixate in the middle. And we switch from U plates to Y-shaped plate. These are the plates manufactured in Turkey. And in 1997, and this was a case of basal invagination with Chiari malformation, a very long occipitocervical fixation have been done. Then the rod screw systems were introduced. More rigid fixation could be done. These are some different types of occipitocervical polyaxial screw and rod plate constructions. Recently, I like these occipital plates, which can have 1 or 2 or 3 midline screw for occipital bone, and for the rods, bilateral rod placement grooves they have. This is one of the cases, intraoperative films. In beginning with at the beginning of 2000s, we then started using those systems, and then switch from very long fixations, shorter fixation systems. This is a case you can see after transferal odontoid resection, we have done an occipital cervical fixation. We have done a publication in 2002 telling how to do those things. But in 2004, Dr. Atul Goyal has introduced that C1 lateral mass and C2 pedicle screw fixation. Then Dr. Harms has improved, popularized the technique. And by this technique, Goyal has also described the posterior reduction of basilar invagination. Then our indications have been more aim related. So this is from 2009, a male patient with basilar invagination and TRE1 malformation. We have placed cage on one side and C1, C2 screw fixation. This is another case with atlas assimilation. This is pre-op and this is post-op. You can see how the tip of the odontoid has get out of the cranium. Yes. Another case, shorter fixation. So you can see how we evolved our techniques from semi-rigid fixation systems with longer fixation points, then more shorter fixations with more rigid fixation techniques. Yes. What is the indication of occipital cervical fixation then? The absolute indication is a traumatic occipito-atlantal instability. Occipito-atlantal instability due to basilar invagination, if it is irreducible, which is, according to Goyal, it is very uncommon. If there is atlas assimilation or dyskinesis of C1 lateral mass, so you can use this occipital cervical fixation again. Tumors and infections invading occipito-atlantal joint, and rheumatoid basilar invagination. Why did we make it a distinction? Because those patients do have low quality of bone, so then you cannot rely on C1, C2 fixation. Relative indications are odontoid resection, Down syndrome and cranial setting, cases with osteoporosis, and complex C1, C2 fractures and revision cases. This may be an algorithm for trauma. First, we must look at if there is an occipital cervical instability or just atlantoaxial instability. In most of the cases, it is this condition. However, even if there is occipital cervical instability, if it is reducible, you can make this. However, if it is irreducible, anterior compression, so anterior decompression and occiput C1, C2 fusion is necessary. So transoral approach is quite restricted in trauma cases. In atlantox cases, I will not talk much about this. In non-trauma cases, let's say it is a rheumatoid arthritis. If there is neural compression and myelopathy, the first question must be this. If there is neural compression and if there is not neural compression or myelopathy, we can just follow up. If, however, there is neural compression and myelopathy, then the question will be again occipitocervical instability or atlantoaxial instability. So, as you know, in rheumatoid arthritis, at the beginning of the disease, it is just an atlantoaxial instability, most of the cases. But if it is neglected, if it is not treated appropriately, then after a while, it turns out to be a basilar imagination. And those cases, the prognoses are somewhat worse than just atlantoaxial instability. Are there technical considerations for occipitocervical fixation? Yes, we use mostly prone position, neck must be neutral, lateral C-arm control, Mayfield head holder. I will never recommend to make an occipitocervical fixation in sitting position. Reduction with traction. We must measure thickness of occipital bone and vertebral artery anomalies. This is very important. Bone graft should be placed between occiput and cervical vertebra. How long must we go down lengthening? This we must evaluate according to the cases, but we should better stay as short as possible. What are the indications to go more caudal? Rheumatoid arthritis because of osteoporosis and multiple pathology, tumor cases, and hyperlordotic cases. Cases with basilar imagination when to add occiput fixation. If not reduced and need odontoid resection, we must do a occipitocervical if C1 is assimilated. In conclusion, there are recently two great refinements: posterior reduction of basilar imagination, C1, C2 screw fixation techniques. And with the current techniques, we are doing less and less transoral surgery. So then our transoral surgery frequency is very, very low. Occipitocervical fixation restricts head movements and has a very high non-union rate. Unnecessary occipitocervical fixation must be avoided. The main problem is the decision for whether an occipitocervical fixation instability or C1, C2 instability present. Most cases should have gone only to C1, C2 fixation. In basilar imagination, if it's reducible, C1, C2 only. If it's non-reducible, if C1 assimilated, occiput C1, C2, and others. I've said these also. I thank you for all. We have postponed our Istanbul Spine Masters program to October, but we are still not sure if it will be possible because of the COVID pandemics. We will have a full endoscopy course one day for this meeting. And we also postponed our spine committee meeting to March 2021. Thank you for listening to me.
Thank you very much, Professor Zalili. An excellent presentation. Any questions? We're waiting for the questions from the attendees. I have a question, Professor Zalili, until the gentlemen here are ready. How do you adjust the position in a practical level? Patient is positioned prone. You're going to do an occipital cervical fusion. Do you use X-ray? What are your landmarks on X-ray? Do you use a mirror on the floor to adjust the position of the head and the chin? How do you play around this?
Yeah, good question. Actually, it must be a neutral position. Neutral. If there is significant buzzer imagination, actually flexion posture may be good for exposure, but it will not be good for the patient's neurology, because in flexion, most of the time, the atlantoaxial instability increases.
Yes.
So it's not good. Another thing, if you don't make a neutral position fixation, then the patient, because the head movements will be restricted, the patient will stay at that position after surgery, which will be very tragic,
Yes.
very bad.
I mean, do you use particular landmarks on X-rays on the C-arm, for example, to get what you call a neutral? Any parameters do you use on the X-ray?
Actually, no. I just look at from the outside. If the person is looking in the neutral position. Actually, in this region, there are two types of flexion movement. One from the upper cervical spine. The other one is from the mid cervical spine.
Yes. Thank you very much.
Please.
There is a question from Dr. Muhammad Sawan, Professor Muhammad Sawan. He's asking, do we need neurophysiological monitoring? Does it add to the safety to this occipital-cervical procedures?
Yeah, you can do it. It depends. However, in certain circumstances, it may be difficult to get good, reliable potentials. If the patient's neurology is too much, too severe. But there is no good evidence in the literature telling that in this region, all cases must be monitored.
Okay, we have another.
For cervical spine, there is not much evidence on that. But for thoracolumbar spine deformities, intramedullary tumors, there are good evidences.
One of the things that have been described, the value of doing neuromonitoring is while you're positioning the patient. And that's why they would ask the surgeons to start the neuromonitoring while the patient is still supine, because while you're lifting him and turning him around into the pro position and adjusting it.
But this is for cervical spondylotic myelopathy.
Yes.
Actually, since we must avoid a hyperextension of the neck,
yes,
especially during intubation, you can hyperextend the neck, which will be very harmful for the spinal cord.
Excellent. Now there is a question from Dr. Muhammad Arnaout. He's asking, do you believe in endoscopic endonasal odontoidectomy in cranial settling patients? Isolated?
Yes, it's a good surgery. But as I said in my talk, the indications of odontoid resection are very much restricted now.
Yes.
Because it is possible to make a reduction posteriorly.
Yes. Dr. Sharif Hassan Al-Khatib is asking, what is your opinion about doing only C1, C2 fixation for treatment of symptomatic Chiari malformation without doing any posterior fossa decompression?
Yeah.
This is an article published by Dr. Atul Goyal.
Yeah, right. Actually, recently there is another paper from a German group looking at the literature and discussing the advantages and disadvantages of that. Although Atul has some rights, and nicely have shown in some in his cases, in some cases, the Chiari symptoms and also the syringomyelia disappears, but there are not much studies on that, which can be accepted as a universally accepted technique.
Yes.
I must tell this.
Yes, so the Professor Goyal has his own idea of the slope of the C1C articulation, the forward anterior slope of the articulation that allows the atlantoaxial instability for the odontoid to migrate up. Professor Magdi Youssef is asking, do you think navigation gives better results, and do you think it's necessary while you're doing these kind of surgeries?
I don't have that option in my department, so I cannot answer it very nicely. But I know some friends are using and telling that good results can be obtained, but there are many other centers who have got that very expensive navigation device, but don't use them. Because during surgery, you can change your position by pulling, pushing, distracting the vertebral bodies. So it is not like cranial. Cranial is very fixed area,
Yes.
but in the spine, it's not that.
So that. Thank you very much. Now, Professor Osama Al-Ghanem, Professor of Neurosurgery at Al-Azhar University, we need to unmute Professor Osama Al-Ghanem, Dr. Wael. Please, could you unmute Professor Osama Al-Ghanem? Dr. Wael.
He's unmuted.
Dr. Osama Bey, could you please unmute yourself? في زرار تحت كده علي، في زرار تحت حضرتك دوس عليه على الشمال.
Okay, I unmute Dr. Osama.
Thank you very much.
Yes. I've seen your lovely pictures and your very interesting lecture, but I've noticed one of your cases has syrinx. Did you, and it's very good to make fixation, but you are not going to help his quadriparesis unless you do artificial cisterna magna. You have to, because syrinx will not disappear by fixation. If you do fixation without doing decompression and artificial cisterna magna, the syrinx will never disappear, and his quadriparesis will not improve.
Yeah. Yeah, this is what Atul Goyal is saying. I'm not too much defending him, but he has in his papers and in his talks, he has nicely shown that in some cases at least, just with fixation, without any foramen magnum decompression, the syrinx may disappear.
Well, thank you very much, Professor Zalili, Professor Osama Al-Ghanem, for the nice comments and the discussion. We are actually on time now. So thank you once again, Professor Zalili, for your fantastic talk. Now it's time for Professor Muhammad Muhyiddin, Professor of Neurosurgery, Cairo University, to give his presentation about lateral mass fixation.
Thank you very much, Professor Hassam. And I'd like to thank Professor Nasser El-Ghandour for his kind invitation to this event. And I'd also like to thank Professor Zalili for accepting our invitation to attend with us this nice spine event. In fact, my talk would be about a technical issue, and at the end of the talk, we should be able to put the lateral mass screws by a freehand technique in a very rapid procedure. First of all, we all know that the lateral mass screws was first introduced in 1980s by Roy Cameli, and it is now widely used for more than 35 years, and it passes standard adequate mechanical testing and is classified now as class 2 evidence-based procedure. The indications you all know that are many, like trauma, reconstruction, degenerative conditions, and even in some pediatric spine conditions. However, before we could choose to decompress and fix posteriorly, we have certain questions to answer. First, question number one: what is the alignment of the cervical spine? Is it lordotic, straight, or kyphotic? And which one is suitable for posterior decompression? Posterior decompression without fixation is primarily indicated for lordotic and possibly, in very few cases, straight spinal configuration. Otherwise, fixation is needed. How rigid is the deformity? This is a very important question and is answered by the dynamic X-rays that should be done in every case beforehand. Because fixed kyphotic deformities are an absolute contraindication to the posterior approach. But a single stage posterior approach with stabilization remains a good option even in the presence of kyphosis if postural reduction restores the balance. Of course, the nature of the pathological process and the number of levels involved and the presence of pre-existing stenosis are all important data to know, because during choosing of the approach, anterior interbody grafting beyond 2 levels is associated with increased failure rate. And in such cases, supplemental posterior stabilization may be required, or even single stage posterior approach may be more appropriate. Also, we have to know if subluxation does exist or not. Severe subluxation or any increase seen on dynamic imaging would eliminate the possibility of standalone decompression, and it requires inclusion of stabilization and diffusion. Also, the patient baseline medical condition is very important. First of all, the age of the patient. Older patients typically are more prone to swallowing dysfunction with anterior approaches. And the presence of severe osteoporosis will also increase the chance of graft subsidence. So it is better in older patients to do a posterior approach, which would be more appropriate. If the patient had a significant axial neck pain, this axial neck pain is attributed to motion across a spondylotic segment. And in this case, the addition of fixation would be better. Okay. We already, regarding this data, choose to do a posterior decompression and lateral mass fixation. So we have to know what is the lateral mass bony structures. The lateral mass is a quadrant, a round quadrant, consisting of superior and inferior facets. It is between the lateral to the lamina. We will find here at the end of the lamina a shallow vertical groove on each side. This is the start of the lateral mass. The end of the bony structure laterally is the lateral end of the lateral mass. The base of the facet superiorly and its base inferiorly is the upper and lower margins. The diameters, it is almost around 1 centimeter quadrant. Superior inferior from it is around 11 millimeter at C3, and it getting larger down to C7 to 1.5 centimeters. Mediolaterally, it is about 12 to 13 millimeters, and anteroposteriorly Strange enough, C6 and C7 levels are smaller than the levels above. As you can see here, this is the height, this is the thickness, and this is the width. Of course, the different variations occur in the width of the lateral mass. It ranges from 8 to 16.1 millimeters. It is greater in males at all levels and is greatest at C6. Okay, this lateral mass structure, we will put a metallic screw inside. So what are the structures anterior to the lateral mass? Anteromedially, we have the pedicle, then the posterior ridge of the transverse process, inferior lateral just above the inferior articular facet, and we have the transverse foramen. This transverse foramen contains the vertebral artery, as you can see here. And the vertebral artery in the transverse foramen is present anteromedial to the anterior center of the lateral mass from C3 down to C5. And at C6, it courses laterally and lies in front of the posterior center of the lateral mass. So when putting care should be given at the C6 lateral mass screws. The vertebral artery arises from the subclavian, passes through the transverse foramen of C6 upwards, then deep in the lateral mass separated by the spinal nerve, and it is totally above C6. It is not at risk of injury as long as the screw is directed lateral to the sagittal plane. The interpedicular foramen or intervertebral foramen, it contains the, as you can see, the spinal nerve here, and it passes through the lower part of the intervertebral foramen. Laterally in the transverse foramen, it divides into larger anterior ramus and a smaller dorsal ramus. The ventral ramus courses anterior to the, on the transverse to form the cervical and the brachial plexus. The dorsal ramus runs posteriorly against the corner of the base of the superior articular facet. If you want to preserve the facet during fixation and its nerve supply, especially in the lower facet and upper one, please keep this nerve healthy during your dissection. Okay, we go strictly to the operative procedure. Go through the white line, in the midline, reach the spinous processes. Then it started muscle dissection till the lateral end of the bony structure of the posterior bony elements. Then we have to draw the lateral mass quadrants. We said that the lateral mass started with a shallow furrow here at the lateral aspect of the lamina and the end of the bony structure laterally, and we draw it like this, and we classify it into 4 quadrants with a central point. The upper lateral quadrant, if you put the screw in, it is safe because it is away from the transverse foramen. So we are planning to put the screw in that outer upper quadrant of the lateral mass. When you want to study the lateral mass screw insertion techniques, you will find many techniques in the literature. The most famous of are Magdel and Anderson. And everyone describe a starting point and the screw direction and the angles, different angles, 20 degrees, 15 degrees, 30 degrees, and so on, and different trajectories, which actually Practically speaking, you cannot do this in the operating theater. You don't have measurements, proper measurements to give you a 25-degree angle and a 15-degree angle like this. So please forget Magrel, forget Roy Camilli, and forget everything about these angles. And just remember this technique, which is a freehand technique of cervical lateral mass screw fixation, without angles, without anything. You will put 10 screws in 10 minutes. Could you hear me, Hussam, or not?
Yes, yes. Clear.
Yes,
We can hear you very well, Imran.
Okay. So we want to do to put the lateral mass screws without angles, without X-rays, without anything, without Roy Camilli, without any technique described, just by freehand technique. So we should expose the vertebrae like this and identify the lateral mass like this, and they start to draw it. Draw the quadrant and then divide it into 4 quadrants. And the central point of the lateral mass, at this point, we should go downward for 1 millimeter and inward for 1 millimeter, so as to be directed upward and laterally. So our entry point would be the middle of the middle point of the lateral mass. We will go downward 1 millimeter and inward 1 millimeter. This is our entry point. Okay, the direction of the screws is like you are giving hands up, praying for God, like this. The direction of the screw should be upward and laterally to the outer quadrant of the room you are in. This is in opposite to the pedicular screw, which has a different direction. So if we put the entry point 1 millimeter below and 1 millimeter medial, and we are directed upward and laterally, we are in the safe upper lateral quadrant, like this. So first of all, we identify the lateral mass itself, identify the quadrants, identify the entry point, 1 millimeter downward and medial to the midpoint. Okay. We identified the entry point. What to do next? If you try to go through this entry point directly to the trajectory you want, you will fracture very easily the cortex of the lateral mass, which is in some patients is more or less fragile. So by sharp trocar or by drill, you should penetrate the cortex perpendicular, vertical, downward first, before you use any screws. And during preparation and penetration of the cortex and the entry point vertically, please don't push too much, because many cases are stenotic canals and already have cord myelopathy. So don't add any trauma. Just do it with wisdom. Penetrate the cortex at the entry point vertically first, not to fracture the upper cortex, the posterior cortex of the lateral mass. Okay. We already penetrated the entry point, and it is ready to receive my screw. I have two guidelines that will direct me so easily to the place I target, to the target place. First of all, we need to know the craniocaudal angulation trajectory. if you can see here, the facet line is the line going parallel to the needed trajectory to put the screw. So if you put the straight end of the McDonald inside the facet joint, and you just put it inside and leave it, this is your craniocaudal angulation trajectory. So when you have that screwdriver, just go to the entry point and make it parallel to this McDonald, you will be in the right craniocaudal angulation trajectory. Okay. What about so the McDonald? So the McDonald will guide you through the craniocaudal angulation. But sorry, this facet, the McDonald facet will determine the craniocaudal angulation, as you can see here. This is the McDonald. This is the probe in the entry point, as you can see, and this is the screwdriver with the screw in it parallel to the McDonald. What about the lateral angulation trajectory? If you put your screwdriver lying on the spinous tip of the spinous process of the vertebra you are putting the screw in, it will take you directly upwards and laterally. So if you put your screwdriver parallel to the McDonald and you put it to lie down on the spinous process and you stand on the entry point we already mentioned, you are safely and freehand without any angulations. You are going up and laterally to the target quadrant in a very safe manner. Please don't forget to prepare the fusion bed, because if you just put screws in the lateral mass without fusion, most probably the failure rate would be high. So we have to prepare fusion. Fusion is the intervening joints, facet joints in between the segments fused. Please correct the joint, and after laminectomy, or if you have artificial bone granules, just fill the space of the joint with these bone granules and just to make later on fusion. Some other colleagues, and especially our great orthopedic colleagues, do some curettage of the vertebrae itself on the lateral aspect and put onlay grafts like in the lumbar region. This is very important. In fact, the efficacy of the lateral mass screw with proper fusion, the fusion success rate is high, with good maintenance of stability and low complication rate. If we stick to this technique, the safety is high with a very small risk of injury to the vertebral artery. Some recommend that you should do to view the real size and real trajectory. You can do a preoperative CT 3D reconstruction of the vertebral bodies, and at the end you will have to conclude, draw the lateral mass, take the entry point 1 millimeter down, 1 millimeter in, and take it with the McDonald here, and lying on the spinous process, go up and lateral, and it will end like this. Perfect. Thank you very much. And now we will see a rapid video about the technique. We have cases like this. Multi-level segmental stenosis with kyphosis. Canal is compromised, like this, and and straight, advanced spondylosis. When we do the dissection, we have to draw first the lateral mass, open the facet joints, put the McDonald in, draw the lateral mass, identify the point of entry, as we said. You can use the drill or the crocker. Take it, do the same step at each level simultaneously. Prepare the entry points at all levels, like this. This is the screw we probe the entry trajectory that it is all bone around, as you can see. And this is the polyaxial vertex screw. And at the end, after preparation, we can take the same trajectory we said with McDonald in place up here and lying on the spinous process. We can put just 10 screws in 10 minutes. As you can see. Lastly, please, when you put the rod here or there in the lumbar region, please take care. You are at the end of the surgery, and many of us are exhausted, and they leave a long end rod here and a long end rod here, and this end with movement of the patient will hit the adjacent facet here and there, and hitting this facet continuously will end in a very severe bony pain, and it will end with erosion of the facet above and below. So please, appropriate rod length is advisable. And this is the end result, as you can see. Here you can see the screws are just in the in proper position. What happened? Okay. My last comments are that in pediatric cervical screws, it's the anatomic dimensions of the pediatric cervical lateral mass screws does not prove safe. And sometimes if you don't stick to the rules, you may have a picture like this with the screw inside the transverse foramen and ending in bleeding and vascular injury, like this case. So it is very important to do it the same way we discussed, and not to go just forward like this and injure the vertebral artery. This is our end result. Thank you very much. I hope you can do it freehand in a very easy way. Thank you very much.
Thank you very much, Professor Mohammed Mohideen, for this excellent and demonstration of the technique and all the technical details and some tips and tricks. There are some questions here, Professor Mohi. We have a question from Dr. Omar Hamed. Wonder if he would like to ask it himself. He wrote here, All techniques, Professor Omar Hamad said that all techniques using screws are quite demanding and carry major complications. I prefer to use Halifax hook systems with or without titanium cables with very nice comparable results. What's your take on that, Dr. Mahi?
My experience with cables, with time, it erodes and fractures either the cable or the bone itself. But
Okay.
the stiffness and the mechanical testing of the lateral mass screw and rods proved very efficient. And the most important thing is that you prepare for fusion. If you prepare for fusion in few months, everything is fused and no need for the instruments at all.
Okay.
So we have to have good instrumentation like the lateral mass. In this way, believe me, Omar, it will be safe. You will have no complication, but do it this way.
Okay. Now, a comment from Professor Mohammed Al-Fiqi saying a fantastic educational presentation. The Professor Mahi is thanking you. We also have, can I ask you a question, Anna, Mohammed?
ده شرف عظيم يا باشا.
Do you do bicortical screws? I mean, do you aim at getting a bicortical purchase, or are you just happy with one unicortical fix?
In cervical spine, we are neurosurgeons. We are not like you. You are brave men. We are not. So in cervical spine, I usually like to have unicortical, but sometimes, especially in the lower C7 and C6, I may have a bicortical screw easily.
Okay. Do you manage to put lateral mass screws in C7, or do you use pedicle?
Yes, I put occasionally. I put in C7, despite the fact that it is small, but I put it. And sometimes when the pedicle is there and we do laminectomy and we can see the pedicle, we can put instead of the lateral mass screw, we can put a transpedicular one.
Okay. Now, Professor Salah Al-Hifnawi is asking, what about revision cases with previous laminectomies?
This is a very good question. My freehand technique is described for the de novo cases with the spinous processes intact. If the spinous processes are not there, then you have to stick to the rest of the technique and imagine that there is a spinous process. The most important to me is to draw the lateral mass. If you succeed to draw it, you can do it.
Right. Okay, Professor Zalili, have a question. Could you unmute yourself, please, Dr. Zalili?
Yes, please.
Please unmute yourself. Dr. Wael, انت عامل
Yes. Yeah, he can unmute himself.
You unmute
يا وائل انت.
It's at the bottom down on the left.
Yes, okay.
Bottom down to the left.
Now,
Yeah.
the host is sleeping.
You're here. You're back with us again.
Yeah, actually, it was really a very nice lecture, especially the technical points. I must stress that the lateral mass screws are semi-rigid systems, not very rigid. The alternative, especially if you want to correct some deformity, is pedicle screw in this subaxial spine. What do you think about it? It has significant differences than lateral mass screw.
Yes, this is a great question from a great surgeon. And I think in cases of deformity, 360 degrees fixation would be advisable because the failure rate may increase with standalone posterior lateral mass fixation. What is your opinion?
Yeah, the main disadvantage of pedicle screwing in subaxial spine is that the pedicle diameters are very thin, and you must go with 45-degree medial angulation. So you may need to make another incision outside the midline incision to place your screwdriver. And you can injure the vertebral artery or root. These are the disadvantages. But actually, if you want to correct the deformity, like kyphosis, it's more reasonable to use it.
How do you use? Sorry, how do you insert your pedicle screws? Do you do a laminoforaminotomy to feel the medial wall of the pedicle and its superior and inferior borders, or what's your
This
tricks
is
on
one
that?
technique, and there are also some entry points descriptions for pedicle screwing.
There is,
especially Japanese authors are doing that too much.
Yes.
Dr. Abumi has introduced that technique, as you know.
excellent. Now, there is a question from Professor Khalid Al-Awami from Benghazi, Libya. He's asking, what's your solution in facing osteoporotic bone and cervical fixation?
In fact, cervical spine is very critical when you consider to inject anything, starting from corticosteroids to painkillers to bone cement. But in some cases, in osteoporotic fractures, we can put inside the small trajectory we have done a screw cement, very small, but take care because leakage here is very dangerous. And if you are facing a good osteoporotic bone, it would be contraindication for some patients.
Okay.
What do you see, Sam?
Yes, thank you very much, Professor Muhammad Muhyiddin. Excellent presentation and some good questions. Now it's time, we're getting on time. So it's time for Professor Mehmet Zalili to talk about his second talk. It's about odontoid fractures. Dr. Zalili.
Yes. Thank you again. Yes, this is still a hot topic to talk, although we think that some issues have been nicely explained, but there are still some points I will try to discuss it. If you look at the instability of atlantoaxial joint after odontoid fracture, there are certain radiologic criteria. One is the anterior atlantodental interval, which should be, this is the anterior atlantodental interval. Normally, it is less than 3 millimeters. In children, it may be up to 4 millimeters. But if it is in the adults, if it's more than 3 millimeters, we can talk about instability. If it is more than 5 millimeter, transverse ligament may be ruptured. Posterior atlantodental interval is another thing. It is at the back. Normally, it is more than 13 millimeters. Yes, here you can see the descriptions. Transverse ligament rupture is another issue, especially if it happens in a type 2 fracture. You cannot do a transodontoid screw fixation. It is best observed on axial MR images and often with neurologic deficits if you see a patient with type 2 fracture and some neurologic deficits, then you can suspect the transverse ligament rupture. Besides, with disrupted transverse ligament, dislocation can occur at 45 degrees of rotation, and we call it atlantoaxial rotational instability. With the transverse ligament intact, complete bilateral dislocation can occur at 65 degrees of rotation. As you know, this is the classical classification of odontoid fractures, Anderson the Alonso classification. However, with the recent technical advances, it was not very sufficient. So recently, we then started to use some sub classification of type 2 fractures. What are they? Sorry. Type 1 fracture is can be treated with the external stabilization only. Non-displaced fracture of type 2, this is so-called type 2A. External support may be an option. If, however, the fracture line is from anterior superior to posterior inferior, like you see here, these are called type 2B. They are good candidates for odontoid screwing. However, if it is the other way, the obliquity is like this, anterior inferior, posterior superior, so better to make a C1, C2 fixation, because in this direction, a good screw purchase is not possible, may not be possible for odontoid fractures. As you know, for type 3 odontoid fractures, external support is enough. Here you can see. So this type 2A, B, and C subclassification has been introduced by Grauer and co-workers, and we call that Grauer and co-workers classification. What are the surgical options for odontoid fractures? One is the odontoid screwing. I will give you some hints of it. C1, C2 segmental fixation. In my previous talk, I have discussed that, which was a Goel arms technique. Posterior C1, C2 transarticular fixation, anterior C1, C2 transarticular fixation, and C1, C2 wiring, which is now mostly a historical thing, and occipitocervical fixation if it is an option for odontoid fractures. What about odontoid screwing? It is indicated only in type 2 fractures. If there is greater than 4 millimeter displacement, greater than 10 degrees of angulation, and posterior displacements are more appropriate for odontoid screwing than anterior. Some surgeons never do an anterior displaced type 2 fractures, never do a odontoid screwing. First 8 weeks after trauma, but some others think first 1 week only. And if the patients come later, then the non-union rate will be greater. So the contraindications, if the fracture line is like this, it may be a contraindication. Transverse ligament rupture, as I mentioned to you before, may be a contraindication. Non-reduced fractures and anterior dislocations may be relatively contraindication. This is the position we can use for odontoid screwing. And some surgeons, if you have 2 C-arms at the same time, it will be more comfortable. But if you don't have it, then you must turn it after every step in 90 degree, so AP and lateral viewing you must look. It's better to use a sponge on the mouth to open the teeth, because the teeth will super positioned with the odontoid tip, and they can cause a problem to see the odontoid screw. And as some friends may think that your incision will be from very up. It is not. You can make at C5, C6 level incision, and then after blunt dissection, you then aim your entry to from C2, 3 disc level. Reduction may be achieved by pushing the distal or proximal fracture segment. Actually, if it is posteriorly dislocated, you can just easily push the C3 body. But if it is anteriorly dislocated, then you must push the C1 anterior arch. Some surgeons prefer to push it with the assistant's finger, which was placed in the mouth. Two screw technique, some surgeons have used this, but I am in doubt, because two screws will occupy most of the area of union, so then non-union may happen. And it's not easy to place two screws in very narrow area, almost 0.8 millimeter diameter, 0.8 centimeter diameter. This is one case, 53 years old male, fall from height, non-neurology, neck pain, posterior displaced odontoid fracture, MRI transverse ligament intact. We then plant a screw, odontoid screwing. This is the post-op films. It looks nice. Everybody thinks that it's very good, but if you look at the AP film, it's not. We had trouble in seeing the AP during surgery because of radiolucency of the table was not good, and then it's on the side. This is postoperative films. You can see nicely it's on the lateral part of the odontoid tip, so it's a mistake. So we then operated again. A second screw is inserted while the first one remained in place. This time we only used AP fluoroscopy, and this is this after second surgery. This is screw. The first screw hole is here. Is in the middle. Probably you can criticize the tip of the screw is somewhat up to the odontoid process. The other technique I have mentioned, C1, C2 segmental fixation, Goel Harms technique. This is actually first introduced by Goel, then popularized by Harms, an alternative to posterior transarticular screw fixation, lower risk of injury to the vertebral artery. Actually, I will also give some details of transarticular screw fixation. But this technique, you can have bleeding over there because of veins, very rich veins there are in this region. But the incidence of vertebral artery injury is very low. What about more classical? It was first introduced by Magyar in 1986, very old technique actually. This is a transarticular screw fixation, but your aim of screwing is very inclinated, so that you may need to make another incision at T1, T2 level to place your screwdriver. Another thing, very important thing, is the variations of the vertebral artery. And severe cervical lordosis, if the chest AP diameter is too much, so if there is kyphosis, so then you cannot do it easily. This is the screw entry point for C1, C2 transarticular screw. But you must also see where the vertebral artery groove is by having a sagittal paramedian CT scans. If in this paramedian sagittal CT scans, if the position is like this is okay. But if there is a high riding vertebral artery like here, you will then enter the vertebral foramen. This is then great bleeding and then risk of brainstem ischemia. What about transarticular screw fixation techniques? There are also anterior and lateral techniques. Lateral has not been popularized, but anterior one is still being used by many others. And for C1, C2 transarticular screwing, some surgeons also prefer to make a C1, C2 wiring, adding a wiring. Injury to the vertebral artery is a big complication. And it's been said that according to the anatomic studies, inappropriate in about 20% of cases. If one artery is injured, the other side should not be drilled, and fusion with conventional techniques should be applied. Otherwise, if you injure both sides, then the possibility of having a brainstem ischemia is too much. Yes. What about anterior C1, C2 transarticular screwing? It is by opening up anterolateral portion of the cervical spine and then placing the screws like you see here on the AP film. This is really less risky for vertebral artery. An alternative is C1, C2 plating, which is not very easy. I've done it in a few cases, but it's not for the odontoid fractures, for tumors mostly. What about the C1, C2 wiring? This was a conventional technique we have used in the 10, 20 years before, many C1, C2 wiring. This is the technique. This is the gully fusion, so-called gully fusion. But we need, however, a post-op halo brace. If you don't, you can have the cutting of the lamina or dislodgement of the wire or fracture of the spinous process or lamina. And sometimes C1, C2 Halifax clamp fixation have been introduced, but it then became abandoned because of high failure rate, especially during rotation, because it's rigid for flexion extension, but not rigid for rotational movements. What about occipital fixation? It's never indicated on odontoid fractures, should only be done with combined C1, C2 fractures, occipital destructive injuries. What about non-union rate of C1, C2 fixation? This study from 2018, posterior fracture non-union has been found 65%, still too high. after C1, C2 fixation. What are the risk factors? Advanced age, long duration between trauma and surgery, if it's more than 2 months, separation of the odontoid fracture if it is more than 4 millimeter especially. This is a retrospective study, odontoid screw non-union. Yeah, it is also possible. The non-union rate has been found 12%. It's not that much. A delay of more than 1 week before operation. Actually, somebody was telling at the beginning of my talk, I told you that in the first 8 weeks they were suggesting odontoid screwing, but a delay of more than 1 week has a risk of non-union. A fracture gap of greater than 2 millimeters has a risk of non-union. Also, odontoideum must be differentiated from odontoid fractures, and in odontoid screw fixation is never indicated in an osodontoideum. I am still getting questions from young colleagues. It's never indicated. It means nothing, because think about it as if it is a late fracture. Even after 1 week, you have non-union rates. I will show you one very old person, 91 years old female. She had a fall during walking, neck pain only, and this was her first films. MRI is suspectful for a odontoid fracture, but no dislocation, no translation. Direct X-ray is okay, but in thoracic CT, you can see multiple level fusion. This is, since we are recently getting involved with many geriatric patients, ankylosing disease we see more and more in the older ages. There's no dislocation, but type 2 odontoid fracture. You can see the fracture line here. She had no surgery at that time. And I saw the lady in 2019. She was 94 years old at the time I've seen her. And this is the posterior dislocation. At the time I saw her, she had severe neck pain and restriction more prominent. She had no neurology still after 3 years, wheelchair dependent due to severe neck pain, not because of paraparesis or quadriparesis. She had also chronic obstructive lung disease, heart disease, anticoagulant therapy, mild Alzheimer's disease. I did not recommend any surgery to her. Actually, since the older persons may fall down during walking because of ataxia, it's very, very common. And if they struck their faces, it's quite common. It's becoming more common in the elderly's type 2 odontoid fractures. We had recently a consensus meeting of the spine committee of WFNS. Statement 1 was in adult patients anterior atlantodental interval more than 3 millimeters indicates transverse atlantal ligament disruption and instability in C1, C2. And if it's more than 5 millimeters, transverse ligament and associated stabilizing ligaments have been ruptured. Second, for anterior odontoid screw fixation, the interval from injury to operation and fracture gap are significantly associated with fusion failure. However, patient age and fracture displacement were not found to be significantly associated with fusion failure. Etiology of osodontoideum remains controversial, but there is now emerging consensus on the traumatic or etiology of osodontoideum rather than a congenital source. But I still believe there are some certain amount of congenital osteodontoidomes. And this is my talk. Yes, thank you for listening to me.
Thank you very much, Professor Zalili, for this wonderful talk. Now, waiting for the questions on this talk.
In fact,
ask a question. I was. Sorry.
The process of the step that Professor Zalili has done in the World Federation of Neurological Surgeons Spine Committee of putting these recommendations last year is a cornerstone to the practice of craniocervical junction surgery. And it answers a lot of issues that can be a question in the mind of many spine surgeons. So I recommend that everybody should have these recommendations as a guideline for his craniocervical junction practice. Thank you, Professor Zalili.
Thank you, Mohammed.
Thank you.
I want to promote our webinars. It is on the website of WFNS Spine Committee. You can see many webinars there. They are already recorded there.
Yes, excellent. Thank you very much. Now, going back to questions, Professor Zalili, do you have an age limit to putting an odontoid screw? I mean, we're talking about type 2 with a favorable angulation of the fracture. It's reduced. Do you have an age limit for that?
Somebody says that in very elderly persons, it shouldn't be done, especially after 60, 65 years, because of the osteoporosis. And the non-union may result with a catastrophe.
Right.
Yeah, I prefer, if I'm operating, I prefer to make a C1, C2 posterior fixation.
Okay.
Actually, there was a trend in the past in the elderly persons making a halo instead of surgery.
Yes.
But then recent publications have shown us that the halo application have more complication in elderly people and even mortality. So then you use even a Philadelphia rigid collar or do surgery. As my presentation, that 91 years old lady have got no surgery, but has got nothing, just pain.
Yes. Two technical things. How do you overcome the gap while you're putting the screw in an odontoid screw? And the other thing, do you aim at purchasing the far cortex of the odontoid, or you just keep the screw short of the surface of the odontoid?
Yeah, as you know, we use their navicular screws.
Yes.
With a cannulated type. First, we use a key wire to purchase the odontoid tip. After being sure that we are inside the odontoid, then we use a screw tap and place the navicular type of screw. Are you asking the length of the screw? It's
yes,
35, 40 millimeters.
Do you reach the far cortex of the odontoid tip? Do you penetrate the tip of the odontoid?
No, it's not necessary to penetrate it.
Okay. And the second thing, we're putting very commonly when you're putting the screw, you find the gap of the odontoid actually widening. So what do you do for that?
But the navicular screw is because of that. It has to compress the gap of the fracture line. Okay. If it is widening, then there is something wrong.
Okay.
Then the non-union will happen. It's not good.
Yes, of course. Now, a question from Dr. Tariq Gabr. He's asking if the transverse ligament is partially torn. Is it absolutely contraindication to put an odontoid screw in?
Right, it is. absolute contraindication.
Okay.
In this
Because
case, the odontoid tip will be stable, but since there is transverse ligament rupture, atlantoaxial dislocation will continue. So then more compression to the spinal cord will happen.
Okay. There is a question from Dr. Ibrahim Dessouki. He's asking, he's thanking you for a great lecture. And he's saying, is there a sharp imaging sign or indicator that we can use to definitely differentiate between os odontoideum and fracture odontoid type 2?
Yeah, actually, there are two etiology of os-odontoideum. One is the old fracture, especially a fracture in the childhood may be seen as a os-odontoideum in the adult ages.
Yes.
Those, the age is a serrated nature. However, if it's a congenital nature, it's not serrated. And there are mostly other type of congenital anomalies like the atlas assimilation or some other things,
Yes.
vertebral artery abnormalities, other things.
Yes. So a question from Dr. Muhammad Khalid. He's asking, is MRI indicated in every odontoid fracture for ligament assessments, for the transverse ligament assessments?
Yeah, I do always. And a CT scan also. Both of them is a good thing to see. Not just the, actually, if you are doing a posterior surgery, you should better see the vertebral artery groove.
Sure.
If you are doing a anterior surgery, you should better see the transverse ligament.
Yes. A question from me here. I would think that having an odontoid fracture and a transverse ligament injury at the same time should be quite rare, because this is like a double level injury. I mean, it's either you fracture the odontoid by the transverse ligament or you cut the transverse ligament. So, because if the transverse ligament is gone first, what would fracture the odontoid? So what's your take on that?
Yeah, actually, in most of the odontoid fractures, there is no neurologic deficits, no neurology.
Yes.
Because, as you know, there is a rule of 3 here. 1/3 of the spinal canal is occupied by odontoid tip, 1/3 by spinal cord, the 1/3 is by CSF.
Yes.
So even if there is some dislocation, it doesn't come to an amount of great compression. But if the transverse ligament has ruptured, there it happens.
Yes.
So in those cases, we must always do a posterior fixation. And if we are retarding the surgery, if we don't do it immediately, we must put the patient in a small traction, not very, very high weights.
Okay. A question from Dr. Muhammad Ahmed. He's asking about the range of movement affection after odontoid fixation. Would there be an affection of the range of movement of the neck after putting an odontoid screw?
No, there is not. This is actually odontoid screw fixation is the most physiologic surgery for the region. You are just placing a screw into the fracture line.
Yes.
There will happen nothing. But with C1, C2 posterior fixation, yes, we can lose some rotational movements of the head.
Yes.
But the patient may not notice that very well.
Yes.
Most of the time.
Well, I think we're running out of time. Thank you very much, Professor Zellini, for the wonderful talk.
Was good.
And thank you for the audience for the nice questions and the good discussion. Unfortunately, I'm not able to go ahead with all the questions because of the restrictions of time. The final presentation is my talk. My talk is about, I thought I'd maybe talk about a pathology rather than within the cervical spine instead of the operative techniques or technical aspects of cervical fixation. Maybe this would be an introduction to another aspect of cervical spine surgery and reconstruction. Let me show you this case. This is a 17-year-old patient that I saw in December 2000, some 20 years ago. Her father was standing in front of my office with these x-rays in his hands. She's 17. She was complaining of severe neck pain and brachialgia. She was myelopathic. She was able to walk, but with difficulty. And these were her x-rays. She was diagnosed with aneurysmal bone cyst, and she had 4 previous surgeries, 2 anterior and 2 posterior. And that was the final x-ray at the time of her presentation after 4 previous surgeries. This is the AP x-ray. You can see a heart rectangle with the spinous process wires and a plate and the big gap of no structures really seen on the x-rays. So, what is aneurysmal bone cyst? An aneurysmal bone cyst is a benign tumor-like, or maybe even a tumor, which is highly vascular, locally aggressive, and relatively rare. It represents about 1.4% of all bone tumors, and it's of unknown etiology. Only in a few years back, oncogenes have been identified in the fibrocytes of the wall of aneurysmal bone cysts in up to 75% of primary ABCs, and this may put it back to be a real tumor, not just a tumor-like condition. 10 to 30% of it localizes in the spine and can be primary or secondary. Primary meaning that the pathology is only an ABC, while secondary means that the patient with a tumor, other tumor like a giant cell tumor or an osteoblastoma, will have part of it showing features of an aneurysmal bone cyst. That's what we call a secondary ABC. Any staging of benign tumors counts them from 1 to 3. And many benign tumors, many aneurysmal bone cysts are either benign active lesions or maybe sometimes even benign aggressive. And that's why it's notorious for local recurrence, particularly when inadequate resection is performed. There has been a big list of suggested treatments. Surgery was, of course, the first type of treatment to be introduced. Also selective arterial embolization, addition of radiotherapy, which I have to say is not anymore an option in ABCs. Intralesional injections with different materials. The most recent is the use of denosumab, which I will talk about a little bit later. And finally, a combination of these methods to treat these ABCs. Surgery is indicated in patients with either cord compression or neurological deficit, or in the presence of spinal instability of deformity. These are the patients who absolutely need surgery. The surgery can be either a simple curettage, but unfortunately this leads to around 50% local recurrence rates. Extended local curettage, meaning you go through the lesion and you curette it, but you make sure you do a total removal, excising the wall of the tumor back to the normal looking healthy tissues using a high-speed burr and sometimes local adjuvants. Unfortunately, cryosurgery is not really an option when you're on the surface of the cord, so local adjuvants can be used in peripheral skeleton, but not in the spine in most cases. And then even en bloc resection has been described in recurrent ABCs. I have some restrictions on that, and I think it's just too much treatment for a lesion that's benign, and that can be dealt with other methods. The other methods of treatment, selective arterial embolization is becoming the gold standard treatment of aneurysmal bone cyst in the absence of the contraindications, which are the neurological deficit and the presence of spinal instability. It's effective in about 74% of patients, or 3/4 of them. Unfortunately, the problem is that it may take up to 10 procedures to control the disease. And it's not suitable, of course, for patients with cord compression and neurological deficits. Intralesional injections has been used in the peripheral skeleton, and Also, other cysts like the unicameral bone cyst in the peripheral skeleton has been used. Methylprednisolone with calcitonin has shown effect in some sporadic case reports. Intralesional doxycycline, again borrowing these methods from other uses and lesions from the peripheral skeleton. And also intralesional bone marrow concentrates of injections, intralesional injections of concentrates of bone marrow with the effect of a possible mesenchymal cells available within the bone marrow that leads to ossification. Again, some few reported cases in patients with ABC of the spine, some of them requiring one or more than one intralesional injection. Finally, something that sounds and seems to be quite exciting is the use of denosumab. Now, denosumab is a treatment that has been used in the treatment of osteoporosis. It's a human monoclonal antibody. It binds to the surface of osteoclasts and leads to a decreased osteoclast formation, function, and survival. And of course, this leads to a result in a decreased resorption of bone and increase of bone mass. It has been used for some years now as an anti-osteoporotic treatment. However, recently it has been described, and this is a paper published in 2018, the European Spine Journal, and it reports a case which responded to denosumab injections over a period of 12 months. So, our guest speaker, Dr. Zalili, has published in the European Spine Journal in 2013 this paper reporting on 18 cases of aneurysmal bone cyst of the spine. The recurrence rate was significantly lower in cases of total excision. I have also had my publication on that. I have published that in the Egyptian Spine Journal in 2012, and I reported an experience with 15 consecutive cases of ABCs. And at that time, complete intralesional resection or an extended intralesional resection led to a complete resolution with no recurrence at all. Again, an experience similar to the experience of Professor Zalili. Now, this is probably the biggest collection of spine ABCs. This is a paper by Stefano Boriani, where he collected patients from multiple areas in Europe, Northern America, and Australia, and looked at 71 cases with spinal ABCs. And the conclusions were that spinal ABCs can be effectively treated with either intralesional resection, en bloc resection, or selective arterial embolization. Going back to the topic of cervical spine, this is my personal case series. These are 8 cases that I have operated upon between January 2021 and March 2019. They were equally distributed to male and females, and the age range was 5 to 17 at the time of surgery. They all presented with axial pain. The 3/4 had radicular pain, and 5 out of 8 had the neurological deficit and a palpable mass. My cohort of patients who had previous surgeries, 4 had no previous surgeries, while the other 4 had different numbers of surgeries, including 4 surgeries, as I mentioned earlier. So 4 patients underwent 10 previous surgeries at the time of their presentation to my practice. I've used the staging of a Weinstein-Boriani-Biagini classification. It's a good typographic description of the lesion from 1 to 12 in a clockwise or an anti-clockwise manner, as shown here. And it also describes the depth of whether the tumor is within the body, into the canal, or extending outside the body, or even encirculating the vertebral artery. I've also used the pathological Anakin classification staging, and 6 were benign aggressive lesions, which is known as stage 3 lesions, while 2 were benign active lesions, or 2 stage 2 patients. This is the like the spreadsheet of the patients, nothing much to see here. And all patients in this cohort of 8 patients underwent combined anterior and posterior surgery. We did not perform selective arterial embolization. At the beginning of my practice, it wasn't available. And then when I attempted to have it performed to one of my patients, it failed once. And then over the years, I have sort of developed a way of dealing with these and controlling the bleeding, as I will tell you in a minute. It will, all patients had the anterior and posterior surgery at the time, 1 day surgery, while only 1 patient was staged. The operative time ranged between 5 to 8 hours, and the blood loss as shown. The follow-up is ranged from 10 to 82 months. All patients reported improvements in their pain. All patients had solid fusion except one, and we had only one patient who developed a local recurrence, which is the case number 7, and 6 months post-op. Complications were minor. One developed a pneumonia that required antibiotics, one superficial infection that required IV antibiotics, and another one case with the local recurrence that was actually controlled by denosumab to date. This is a 5-year-old male who was presented with spastic quadriparesis and had previous anterior and posterior surgery 9 months earlier. You can see a huge tumor here extending from C6 down to T1 and with extensive compression of the cord. You can see here the red arrow shows the cord compressed to one side, and you can see surrounding the tumor surrounding the vertebral artery on the right side. This is the intraoperative photograph showing the spinal cord. You can see the spinal cord here, and after resection of the tumor to the right side, you can see the nerve roots here coming out from the cord, and this is the cord, and there is a bridging mass of bone here because of a successful fusion with the previous surgery. The patient was turned around and an anterior exposure was done and a complete resection of the tumor, and used at the time I used a fibular autograft to strut it. Was not able to go down to T3 with an anterior cervical plate, so, and the stability was good enough and did not require a plating. This is the patient that I started the presentation with. This is the 17-year-old, severe neck pain, radiculomyelopathy, and she had 4 previous operations with this fixation on. You can see the tumor, a big tumor extended to the outside. You can actually palpate the tumor on the side of the neck. And you can see here the yellow arrow showing the vertebral artery, the red and blue arrows showing the tumor pushing the carotid sheath, the artery in the vein superficially to the underneath the skin, and with the severe cord compression. So the plan was to do an anterior vertical incision at the front. This is a patient that had the anterior surgery at one stage and a week later had the posterior surgery. We did a vertical incision on the side where the tumor was. You can see the scarring, the transverse scar of the surgery, previous surgery. And after removal of the tumor, you can see the vertebral artery here with the white arrow exposed and the tumor removed from around it. And the cord is in the middle of the picture. You can see it here with my cursor. This is the spinal cord. Then a week later, we attempted to do the posterior surgery, and the posterior surgery is like this. This is a very important technical point when you're dealing with aneurysmal bone cysts surgically. My way of doing it is to expose the tumor. Don't get into the tumor until you are ready. So basically, you do your dissection, surround the tumor circumferentially, and then once you start the resection, you don't stop, because resection controls the bleeding. So the bleeding will stop once you completely resect the tumor. So you have to be ready with a good anesthetist, and of course prepare a good amount of blood. But I mean, you don't start the resection unless you're ready, and you're going to start and continue doing it until you remove it totally. The more you resect, the less the bleeding becomes. So this is exactly what we do, surrounding the tumor with the approach. And then this is after the resection. This is the spinal cord. The blue arrow shows the spinal cord here. And at the time, this was 2001, I had plates. So lateral mass screws at the top and the pedicle screws at I think C7 and T1 at the bottom with the plates. Surgicel with the black Surgicel here to control the bleeding. And then this is the post-operative MRI after inserting anteriorly a titanium expandable mesh cage, and posterior the lateral mass screws and the plates. This is 32 months following the surgery. You can see the fusion of the bone and the calcification of the lesion here. And then you can see here the bridging of bone even within the cage. You can see it clearly here and a solid fusion. This girl is now a mother of 3, and her condition is completely resolved. You can see here with the close-up the bridging bone even within the cage, so you can see it within the cage. So, going back to the different options, I think it's reasonable to consider selective arterial embolization as the primary treatment of aneurysmal bone cysts, provided that the patient responds to it, which happens in about 3/4 of the patients. You have to remember that this will require commonly more than one procedure of embolization. You can consider intralesional injections if selective arterial embolization is not suitable or ineffective. Surgery is indicated if the above fails or in the presence of cord compression neurological deficit, and also, of course, in the presence of spinal instability and deformity. And again, the 8 cases I'm talking about are patients who had these conditions and therefore required surgery. Denosumab is actually a potential treatment when local recurrence happens. It's quite exciting. The only problem with denosumab is that we don't have an experience giving it in young children. We have to be very careful, and it's a relatively new drug. It's been in the market for some 8 or 10 years, but we still do not have experience in using it in kids. So that's why its use is a little bit in a shy stage at the moment. And to conclude, a complete and a thorough intralesional resection of aneurysmal bone cysts eliminate local recurrence, except in one case, and in that case, denosumab became a valuable salvage. I have not used selective arterial embolization in this case because they required surgery and the technique was not available to me, or at least made up value when I asked for. The technical tips that I think are very important, that you have to surround the tumor before you go into the tumor and do the resection. You have to be ready. Once you start the resection, you have to go and do it, continue doing it. You don't pack and wait and all that. You just go ahead and do the excision because this controls the bleeding. And finally, reconstruction can sometimes be challenging and have to be very well thought of. I thank you very much for your attention.
Great presentation.
Thank you very much.
Thank you. دكتور ناصر، حضرتك سامعني؟ دكتور عمر.
يا دكتور محمد. يا دكتور محمد.
دكتور ناصر كاتب ان
احنا موجودين. maybe there are some questions.
كاتب ان الاجتماع القادم يوم 12/6. النهارده 12/6.
يقصد 19.
Mistake. I'm sorry. I'm sorry. It is 19.
يعني please.
I will correct it right now.
Okay.
Any questions?
Thank you, Professor Zelili, for joining us.
I thank you.
Anybody would like to?
Organizers, all professors, for having me invited.
Okay, let me finish this webinar. At the end of this webinar, it was a successful scientific session. Thanks to all our great speakers, Professor Mehmet Zelili, Professor Muhammad Muhyiddin, and Professor Hussam Salah. I hope you join us our next webinar next Friday about endovascular neurosurgery.
Dr. Nasser. Dr. Nasser.
Thanks to organizing committee.
Dr. Nasser.
Thanks to Eva company. Thank you all. Goodbye.
دكتور ناصر.
دكتور البرزنتيشن بتاعت السمباتكس احنا لسه ما قلناهاش.
دكتور ناصر.
البرزنتيشن
انتوا ما فكرتوناش ليه؟ ما طلبتوش من المودريتور بدري.
انا قلت للدكتور حسام.
يا دكتور حسام ماله يا عم؟ اتفضل حضرتك. انت قلت للدكتور حسام.
اتفضل يا دكتور وائل. اتفضل يا فندم.
Many thanks. First of all, I would like to thank firstly Professor Dr. Nasser El-Ghandour, President of ESNS, for this valuable international webinar. And also, I would like to thank all the speakers and moderators for this valuable international webinar. From the behalf of Eva Pharma, we would like to introduce our product for neuropathic painkiller, the FDA-approved once-daily neuropathic painkiller, which is the Sympatix. The best because it has two items: effectiveness and compliance. The Sympatix is as a painkiller indicated in different indications for diabetic peripheral neuropathic pain, fibromyalgia, chronic low back pain, and osteoarthritis pain. The Sympatix is a duloxetine. It is a member of SNRI, serotonin norepinephrine reuptake inhibitors, which blocks the reuptake of the neurotransmitters serotonin and norepinephrine, which and so increase the level of these two neurotransmitters in the nervous system. From the recommendations and the guidelines, all the international guidelines recommend the Sympatix as first line of treatment in treatment of neuropathic pain, like International Association for the Study of Pain, European Federation of Neurological Societies, and the French Pain Society, and also Danish Pain Society. The Sympatix had an FDA approval in the chronic low back pain, including sciatica, spinal stenosis, herniated disc, ankylosing spondylitis, and spondylosis. I will share with you two different studies for the effect of the Sympatix in the treatment of chronic low back pain. The first study was a 12-week study, fixed dose, randomized, parallel, placebo-controlled, double-blind study. It compared the Sympatix with the placebo in the pain reduction, and the conclusion showed that the Sympatix significantly had a greater pain reduction on the pain score. Also, another study showed that the effect of duloxetine with chronic low back pain, it was a 41-week uncontrolled dose blinded study, and it reached to 54 weeks in patients with chronic low back pain, and this encouraged the use of the duloxetine as it is effective in controlling chronic low back pain for extended period of time. This long time showed also no new safety concern were noted in the extension phase. The recommended dose for Sympatix is 30 milligram once daily, which gives a better compliance. For more severe cases, we can initiate, start with the patient with 30 milligram for 1 week, once daily, and then increase to 60 milligram once daily. Sympatix can be taken with or without food. Finally, the Sympatix has three concentrations, 20 and 30 and 60 milligram. It has FDA approved in pain conditions like diabetic peripheral neuropathic pain, fibromyalgia, chronic low back pain, and osteoarthritis pain. It has also a dual mode of action as it acts on the neuropathic pain and mood stabilization, and thus improving the quality of the life of the patient. Also has a better compliance through the single daily dose, which make a convenient dosing regime. Excellent tolerability, has lower incidence of side effects, which subside quickly after the usage. Also have several evidence-based guidelines which recommend the use of the Sympatix as the first line of treatment for neuropathic pain. Finally, I would like to thank Dr. Nasser El-Ghandour, the president of ESNS. I would like to thank all the speakers for this valuable international webinar. Thank you.
Thanks, Wael. Thanks to Eva Pharma. Thanks to our speakers. Thanks to participants. Thanks to organizing committee. See you next Friday. Goodbye, everybody.
Goodbye. Thank you very much once again, everyone. God bless you and stay safe.